Next speaker is going to be Rick Weiss, who's going to be speaking to us about the application of hand-assisted approach for Crohn's disease.
Thanks, John. And certainly you've already seen probably a lot of the things I'm going to talk about. Other people have actually shown you, how it can be beneficial to do hand-assisted surgery for Crohn's disease. Unfortunately, like many of us, we don't have any. I don't have any disclosures yet at this time of the year. We all know all of the advantages, or at least potential advantages, of laparoscopic surgery for whatever disease process we're going to be dealing with. As you've seen, colorectal laparoscopy can be very complex for a variety of different reasons, yet it's extremely well established at the current time for almost all forms of treatment of colorectal disease, whether we're talking about inflammatory bowel disease, diverticular disease, polyps, etc. As far as Crohn's disease goes, as you've seen by the talks over the last hour or so, it's not just one operation, it's many operations based on the location of the actual Crohn's disease itself. In many instances, Crohn's disease surgery, at least from a laparoscopic standpoint, is not ideal. The ideal candidate rarely exists. And the reality of it is many of these patients have had prior laparotomies, they have complex disease, they have phlegmons, they have fistulas, and these can really be very, very difficult operations. And from the surgeon's perspective, and as you saw from some of the questions early on that we posed using the audience response system, there are many people that really don't have a lot of experience for whatever reason, whether it's that there's never a role for laparoscopy or hand assist, whether they selectively use it, or as you saw across the panel, many people on our panel would try and do almost every case laparoscopically, with the exception of maybe a few, which we'll get into in a second. But the bottom line is all of these are just tools in your armamentarium, and they may or may not have specific reasons to do so. Clearly, there are poor candidates for laparoscopy or hand-assisted surgery. If you have really diffuse jejunal ileal disease, an extremely large phlegmon or mass that you just don't think that you're going to be able to manipulate well, or an unfavorable abdomen based on your own experience, those are probably not good cases. Saying that, I think that you lose very much by just putting a scope in. Often you're very, very surprised at what's there and what you can and actually can't do. And even if you can't do the whole operation purely laparoscopically or hand-assisted, often you can limit the incisions and things you actually do extracorporeally by starting off that way. But this would be a patient, if you saw this preoperatively, probably not a good indication for anything but a laparotomy. And again, there are some other poor candidates, which you can read there, and people have talked about that previously. Just if you look at overall for Crohn's disease, there's been some meta-analyses. This is specifically for lleocolic disease, and really all of them favor the laparoscopic approach for a variety of different reasons. Pataki just showed you some complex disease that can also be managed laparoscopically. But are there really shortcomings or limitations of laparoscopic surgery that maybe hand-assisted approaches may benefit you as the surgeon, and then therefore you as your patients? Certainly you lose tactile sensation, which you can restore with hand-assisted surgery. I find that for Crohn's disease, these big bulky masses, often they're much easier to manipulate with your hand in there than just these small little instruments. And you're going to need a fairly good sized incision anyway to bring that pathology to the outside world. In addition, some of the things that you do standard open, you can reproduce those much better hand-assisted than you can laparoscopically. And certainly the longer procedures, the total proctocolectomies and the total abdominal colectomies, which people have alluded to are sort of boring and tedious, they are, but I think hand-assisted approaches will definitely speed that up. So putting your hand in, I think, for Crohn's disease, probably very specific indications, unless you're just a pure hand assist person and that's what you do all the time. But certainly I think for the total abdominal or total proctocolectomy, that's probably the best use. Me personally, if I ever find patients who fit into the category that you could do a segmental left-sided colectomy, I would do that because hand assist is my preference for diverticular disease. And again, if you're having trouble with ileocolic for whatever reason, because of a large phlegmon, it may be beneficial to do so either right off the get-go or prior to converting to open surgery. The definition of hand-assisted surgery is really the insertion of your hand during a laparoscopic procedure while maintaining pneumoperitoneum. That's the pure definition. But there's many things that you can do through your incision that aren't purely done laparoscopically, and yet you can still get the benefits of hand-assisted surgery. I think we've talked about some of these advantages or things that you get when you put your hand in there. Certainly you can feel things better, but you also can tell where your hands are, where your instruments are. Your spatial relationships are much easier to sort out. You can retract better with your hand, and you can certainly do a lot more blunt dissection. And if you get into trouble with bleeding, it's much easier to control those areas very quickly than with small laparoscopic instruments. And depending on how you use hand-assisted surgery, you can certainly reduce the number of ports that you would use compared to conventional laparoscopy. I personally use hand-assisted surgery mostly in conjunction with working with residents, so I'm more of the assistant so that my ports aren't decreased that much. But if you're the main surgeon and you're not having a lot of assistants, you can really drop down to 1 or 2 ports other than a camera port as opposed to more ports. And again, your hand essentially is 6 different instruments. You have your whole hand, but each one of your fingers can do some very specific things. It's a paradigm shift. The incision is the first part of the procedure rather than the last part of the procedure. And therefore, you can, although you don't have to, you can do components of the operation through that initial incision early on. And some people would say that that's not pure hand-assisted surgery or not pure laparoscopy, but I think it's the results in the end that matter, not all the things that we argue about in the middle. And certainly you can use it as a bridge. There are some people who would contend that, hand-assisted surgery isn't laparoscopy. Some people, make the comments, if you put 1 hand in, why not put 2? And we heard these same things when we were doing laparoscopy 20 years ago. I do think that there is potentially one significant detriment, and that's the cost of the devices. But again, if it's really faster or more efficacious, you'll make that up in your operative time pretty easily. At least in the United States, we only have 2 devices available to us, the gel port by Applied Medical, and right now the dexterous from Ethicon. It also has these fingertip devices, which I have no experience with at the current time. You've seen people put the hand assist device over the pathology or in the midline. I almost always put it in a lower midline or fan and steel incision, probably 95% of the time fan and steel. If I really think that there's a chance of converting, which I haven't converted anything in my last 100 cases or so, I would do a lower midline incision. And as I said before, you can do as much or as little of the operation the way you would do it standard laparoscopy as you want. I tend to cheat a lot, to be very honest with you, and I'll explain to you, what that means in a minute. But I think in the end, the benefits are the same. I don't think it matters how much you do under pneumoperitoneum, not under pneumoperitoneum, through the incision, not through the incision. In the end, it's the same. And these are just 2 examples, relatively big people. Both of them had total abdominal colectomies. This is through a lower midline. This is through a fan and steel using a hand assist device. If I'm going to do a segmental left-sided colectomy, and again, that's not very common in Crohn's disease, but if you were to do it, but this is my standard setup for diverticular disease, I tend to do a medial to lateral dissection for benign disease. For malignant disease, I do medial to lateral. I personally, again, think that you're jeopardizing the nerves for benign disease if you go medial to lateral, even though it's a great way to find the ureter. And it's an easy way to get to the vascular pedicle, but I don't think you have to do that for benign disease. I go lateral to medial and do all the steps that you would normally do, but I do it in a slightly different way. I put my gel port in first, and then through the base of the gel port, without being under pneumoperitoneum, I mobilize 3 to 5 centimeters of the sigmoid colon laterally through my gel port. I find my ureter, because that's the biggest step in the operation, is finding the ureter. I find most of the time it takes less than 3 minutes to find the ureter, open through that, and then I go back to pneumoperitoneum, mobilize the left colon, take down the flexure if needed, which most of the time we would do. And then most of that time I'm operating between the patient's legs with the left lower quadrant port with an energy device. And then I move to the right side of the table to do the vessels, divide the vessels as you see fit, either with staplers, sealing devices, etc. And then often, if I have a incision right over the sacral promontory, I'm going to divide extracorporeally my colon and do my anastomosis in an open fashion through that small incision. But again, you can do any components of these any way you want. And again, in the end, I think you still get the same benefit. Why do I do it this way? I think it's easy, it's fast, it's safe, and it's cost effective because it's time saving. And the outcome is similar, if not better, and we previously presented this last year here at SAGES. If I do a total abdominal colectomy, the left side's identical to what I just told you. The right side I almost do as a pure laparoscopic operation all the time. And the pelvic dissection, if we're going to do a proctectomy, we start off laparoscopically and then at the very end lift off the top of the gel port and usually use a TA stapler or do an intersphincteric resection depending on what we're going to do. These were our first set of cases that we did. They're not necessarily for Crohn's disease, but these are the operations that we did. Relatively high conversion rate, at least initially, but as I mentioned to you now, it's exceedingly rare to convert unless you consider all hand-assisted surgery converted. But I think that the big savings here from our standpoint is time, 40 minutes less to do it hand-assisted as opposed to straight laparoscopy, a little bit better hospital stay, although I'm not sure that that's true, but it certainly is shorter. But essentially they're equivalent in everything else except for time. Wound infections and everything else were very, very similar. My next 200 cases, like I talked to you about, I have almost no conversions and things even look like they're improving somewhat better. The things that we don't really know because it hasn't been around long enough are there going to be more ventral hernias? Is that going to depend on the extraction sites? That's yet to be seen. My personal and other people's experience is that you would think that there's going to be more adhesions when you put your hand in there and move things around that way, but that hasn't been my experience and other people's experience. I think there's almost no adhesions most of the time, even if you do a hand-assisted approach, say, for a total abdominal colectomy and then come back and do a pouch later. There may be some reimbursement issues here in the United States eventually where certain insurers may consider a hand-assisted approach a non-laparoscopic approach and may pay it as an open case, but at the moment, most of them are reimbursing as if they're laparoscopy. Is there any literature to support anything that I just said to you? There really isn't much. There's only a single paper out there just published in March of this year for HALS purely for Crohn's disease, and you can see it's 38 patients over a 14-year period. They had 3 groups, open, straight laparoscopy, and HALS. The patients were very similar as far as their characteristics went. And these are the operations that they did, mostly extended colectomies of one form or total abdominal colectomies. What you see clearly is that these are longer operations when done in some fashion laparoscopically, but again, much faster in the hand-assisted approaches than in the straight laparoscopy. So again, I think that hand-assisted colectomy, if you're going to use it, gives you all the benefits of laparoscopy, possibly with some faster operative time, specifically for the larger operations that one is going to do that way, but all the other advantages. So what's the current role for hand-assisted surgery in Crohn's disease? Well, I think a lot of it is our preference as the surgeons, but I think the places that it makes the most sense are certainly total abdominal colectomy or total proctocolectomy. I personally think that left-sided segmental colectomy, if and when it ever comes up, which is not that common for Crohn's disease, is an excellent way to do it. And if there's a large phlegmon or you're having difficulty with straight laparoscopy, using it as a bridge prior to converting to pure laparotomy can save a lot of full conversions. But I think you have it as a tool, just like laparoscopy, and you use it as you see comfortable. So my point is, I think that you should use your hands. They're amazing. They can do some amazing things, and they can really help out when it comes to Crohn's disease. Thank you very much.